Welcome to Chris. Chris, I hope you're feeling very honoured to be the first speaker of the new academic year. Chris is a GP and a researcher. Like quite a lot of our researchers at SHA, they have a clinical role as well as doing research. He's a professor of primary medical care. In terms of his research interests, his interests are around persistent physical symptoms and somatic illnesses. In terms of his research method style, as I said earlier, his area of work is in health services research and particularly analysis of large-scale data to understand clinical practice and healthcare use. So Chris, I'll hand over to you now, if that's okay.
Okay, and hopefully, is that showing my slides on the screen?
Yeah, I can see them. That's fine.
You got those. We're good to go. Okay, so thanks very much, Claire. Yeah, my name's Chris Burton. In this SHA mini masterclass, I'm going to be talking about an approach to research, the intensive longitudinal methods, and how we've used them to study illness experience in long COVID. What we'll do through the session is, over the next half hour or so, I'll introduce the method approach to you. And for those of you who know a little bit about it or thinking, would it be interesting to use this, some practical questions to think about if you're considering using it for a study. I'm then going to show you how we use this method in a study of long COVID that's been published. So I'll give you the link. You can look it up if you want to. And then finally, what I think has been an innovative step here is I'm going to show you how we've taken personalized data reports from that study back into a round of interviews with people to further understand illness experience. So what do I mean by intensive longitudinal methods? Well, they're an approach to collecting self-report data in real life and usually in real time and using digital technologies. The aim being to collect repeated bouts of the same data over usually a quite short time frame. There are a couple of particular kind of brands of this. At the bottom, Ecological Momentary Assessment, probably the commonest term used by psychologists and behavioral medicine people who tend to use this approach quite a bit. Experience sampling is another term. As ever, when it comes to terms for research, you can find people who argue that their version is different from everybody else's and theirs is the right one. I confess I tend to use them all a little bit interchangeably. I'm going to try and stick with intensive longitudinal methods because that's a generic term. What are they good for? Well, if you want to understand something, study something, where it makes sense to have repeated sampling of some sort of consistent construct, pain, or, how strongly do you want to drink alcohol, that can be reduced to a simple scale. So no 20-item questionnaires here, please. And which are known or suspected to vary in time. So you don't just want a single snapshot. Where you want to understand either the extent of the variation or the contexts and factors associated with it. Then if you meet those criteria, one of these might be up your street. And thinking across the range of stuff that happens in the Centre for Health and Applied Research, the behaviour stuff, public health, policy and interventions in relation to alcohol, as well as experience of illness and medical treatments and conditions, all potentially could sit in this space. What does a study look like? Well, here's an example design. It's the one I'm going to show you in 5 minutes time, but just let's use it to understand how it works. There's just a preliminary phase, which is a bit like any other study, recruitment and enrollment. You want to get your baseline measures, whatever they are. And then because we're running it on an app, there's the download and registration. And because in this one, we also use physical activity sensors, wrist accelerometers. There's that setting up. And then we chose to do a run-in phase to get people a little bit used to it, doing twice a day entry. And because we were running this during the pandemic, we were having to mail out kit to people and things. So there was a run-in, and then there was 14 days during which people taking part got a reminder on their phone every 3 hours from 8 a.m. to 8 p.m. To enter a short survey through a designated app. And at the same time, they were continuously wearing the accelerometer day and night. And the sort of things you might look at in there, so in each 3-hour period, we'd record over the last few hours, how have you been, fatigue and other symptoms. We'd also could ask some prospective things, you know, how much energy do you think you'll need in the next 3 hours? How demanding do you think the next 3 hours will be? Or at the end of 3 hours, the recall ones. How active have you been in the last 3 hours? How demanding has that been? So there's, you can put in kind of right now or looking forward, looking back type of questions. So that seems awfully complicated. Why not just do some interviews or a standard survey? Well, the reasons for me and this, firstly, symptoms are variable. You know, you always do that thing where you interview somebody and say, yeah, I'll score it right now. It's not bad, but I was terrible yesterday. Memory is flawed. We all have recall bias. You know, if we're lucky, we'll remember the first, the worst, and the last. Usually it's just the worst and the last, the most recent. Everything else is conditioned by those. So asking people to think how they were a day ago, a week ago, over the last month is always going to be flawed. And often for these things, context is important. You know, it's around where you are or who you're with that may affect things. And again, that doesn't come easily out of surveys or interviews. The other thing, particularly with surveys, is people tend to fill in the gaps. You know, if they've said they're trying to help, they'll fill gaps in. And if you give them paper diaries to fill in, they'll religiously fill them in. With digital stuff, if somebody skips, it's okay. Everybody misses some. You can't go back and fill stuff in with what you think was the right answer. So there's various things, advantages there. If we're thinking of using this approach, then it's important to think, what are we actually trying to measure? Not just the thing, but the phenomenon, but the mechanisms, the pathways, whatever that we're looking for. Are there validated tools, particularly for the intensive methods? You know, there's a very good 20-item depression questionnaire, but somebody very smartly reduced it to 4 items. We didn't use it here, but you know, I've seen it used elsewhere. That is doable within a repeated sampling thing. What do we think is the time scale of meaningful change? Do we think that symptoms are going to be different now compared to a few hours ago? Well, if you talk to people who experience fatigue as part of their illness, the answer is often yes. And so we went for a fairly intensive short period sampling. And then a question about, do I want kind of to get data regularly, predictably, at about the same time, so you know it's coming, the reminder's coming, or do you want to catch people in lots of different settings? You know, if you say 1 o'clock plus or minus half an hour, that could be still in a meeting or at lunch or going for a walk or getting stressed about the talk you're doing at 2, any of these things. Do you want the randomness or do you want the consistency? Asking anybody to take part in one of these studies is quite an ask. You've got to have a reasonably motivated participant group because this is a chore. It's fine answering a quick survey, but doing the same thing repeatedly for a fortnight is a bit of a chore. So what do you know, how do you balance it? Clearly kind of co-development of the study and PPI and just thinking about what you're looking for is really important, informing that, you know, if you want 70 data points, those are 3 different ways of getting them. What timing? I've already mentioned this. Do you want fixed time points or semi-random? How intrusive do you make it? there's going to be some sort of reminder to put a beep, a notifier, you know, it's 12 o'clock, you're meant to put an entry in, beep. I can ignore that. Do you put reminders? Do you allow people 5 minutes afterwards, 10, 15 minutes? Where do you stop? You know, you just got to think through these kind of questions, both from a design and from a user perspective. And finally, like any good research method, these things need critical friends. The tech that you're thinking you're going to use, is actually up to it? Have you designed it so that people will complete it? And can you analyze it once you've actually got the data? And the analysis is not straightforward. Well, some of it's fairly straightforward. I'll show you some fairly straightforward things, but there are a lot of things going on here, and thinking about this as data at different points within the same person, perhaps grouped as different points within the same day within the same person, and possibly with the persons grouped in you end up with lots of different levels of data. And if you're thinking about between person analysis, you have to think about linear mixed effects, multi-level models and things. One of the other things is that your data are, from this sort of study, these data points are not independent of each other. They are in a time sequence. So you need to bear that in mind as well. So that's kind of the principles of design of this sort of stuff. What about an actual study? What did we do? What did we find? So this study was carried out, the pilot in late 2020, so it was designed from the middle of 2020 onwards, and then ran late 2020, early 2021. We had participants with long COVID. This was before clinics were getting set up or anything, so these were people who self-identified and had joined a peer group that was active in supporting research and participation in research. We used, not surprisingly given the context, an online recruitment and consent process. We had about 10 different survey measures as baseline measures. So that's when your 20-item validated tool comes in at the start or the end. And colleagues at Sheffield Hallam customized some stuff that they'd already got to produce a smartphone app that people used to collect the data on. We used a mixture of visual analog and categorical scales, and as the sort of graphic earlier indicated, people wore a wrist accelerometer for 14 days or so. We, in each data entry thing, there was overall a question about how overall on a sort of visual analog scale up to 100, 0 to 100, how well or unwell do you feel? And then some symptoms. We only asked them about pain once. I forgot to remove it when I put it in the list twice, but yeah, fatigue, pain, breathing symptoms, lightheadedness, cognitive difficulty thinking, taste symptoms, feeling anxious, and we left a slot for other as well. We asked them to describe how demanding the last 3 hours had been, physically, mentally, or physically, emotionally, and cognitively. And we asked them how demanding they expected the next 3 hours to be as well, and how active they anticipated being. The left-hand one, that's the same data collected. I'm just moving it along. So the analysis, we used an approach both within and between individuals. For single variables, say pain, we looked at the range and the degree of autocorrelation, the extent to which data at one time point was related to data at the previous one. And we looked at correlations between variables. We also used a fancier technique called Gaussian vector networks on vector network, graphical vector network Gaussian, just rearrange the words. And we also looked at the relationship between physical activity and symptoms. I'll show you just 3 shots of the results. The first one is the sort of distribution of symptom severity. Now each of the panels in this grid, each of the 4 panels represents 1 participant, and each of the blobs with a line represents the average value, the mean of their score on a 0 to 100 scale, and the range of their scores over the 2-week period. And you can see that the one in the top right, actually most of their symptoms were in the kind of 80 to 100 range pretty much all the time. But the others experienced quite a large amount of variation with most of the symptoms. And certainly that was broadly, we thought, in keeping with patients' accounts of volatile and unpredictable symptoms. In fact, if you measured the autocorrelation, that was low. The score for symptoms at one point for many people was effectively unrelated to the previous 3 hours one. These symptoms are swinging around quite a lot. Next, I'll show you the correlations between the symptoms. And what we aim to do there, because we've got 60 or so data points for each person, is say, okay, if we consider all those data points and look at the correlations between, so when you were having difficulty, having a lot of breathing symptoms, how was that correlated to a different symptom? And we've represented those as heat maps where the density of the color represents the correlation coefficient rather than using numbers on the charts. And you can see, firstly, that up in the top row, some people had quite a lot of symptoms correlating quite a lot with each other. And in the bottom row, other people had very little correlation between symptoms. If you go a little bit more deeply and kind of go, let's see if there's any two people that are more or less the same, there aren't. Not just in that 9, but in the whole 70 or so sets. There was no kind of obvious, these people are twins. And there were very few clear patterns that would say, this looks like a separate phenotype. So the correlation patterns look strong, they seem to be real, but they do differ lots between individuals, idiosyncratic. Every person's heat map was different. And taking that a step further, we looked at we were able to look at the association between variables using this more sophisticated and more conservative approach using vector-graphical models. And what you see in the center is a kind of pooled, this is the average partial correlation of these things. You can also do between person ones as well. And you see that some links, such as between fatigue and cognitive thinking difficulty, are relatively strong for this sort of data. And similarly between fatigue and pain. Others are notably weaker, and many of the links actually don't happen. So anxiety only really links to difficulty thinking and isn't correlated with any of the other things. Similarly, pain goes with fatigue, but not really with the other things. So you get a sense of the connectedness. Again, each person, we were also able to do this on a kind of lagged, this compared to your fatigue now compared to your lightheadedness 3 hours ago or whatever. But again, the block on the left shows individual person networks, and you can see that they vary. I'm not going to try and decode them any further than that, just as a picture, if you like. Finally, we looked at the relationship between symptoms and activity, and particularly we were looking at the concept or the construct of post-exertional worsening of symptoms or post-exertional exacerbation. This quite rapidly became a kind of important issue in the patient discourse and the lived experience discourse about symptoms in long COVID. And it sort of links to a similar experience in ME and chronic fatigue syndrome. Difficult to pin down, so we had a go. And the approach we took, and it's not perfect and you can challenge it, is to say, well, we'll take the most active based on the accelerometer period in the 14 days, and we'll center data on that, and we'll look for 72 hours before and 72 hours after. And what we should see, if we're looking for post-exertional worsening, is a rise between about 18 and 36 hours after the peak activity. This is the sort of common sort of description. So what you're seeing there in the green lines is one sort of squiggle from left to right, centered on the most active peak for each person in the study data set. It was 69 who'd got app data and accelerometer data. And you see that the highest points come in the middle. That's what you'd expect. What you also see there is that at each 24-hour interval after that, there's a sort of an additional peak that's not quite as big. And that kind of makes sense, because if you're most active between, I don't know, 2 o'clock in the afternoon and 5 o'clock on one day, that probably followed with being most active about the same time on other days as well. We then looked at symptoms, and I'm showing you this with overall symptoms, but we get exactly the same pattern with fatigue. And essentially, there's not a lot to see. And that's a bit awkward. However, we've gone a little bit more into this and made a set of criteria to sort of say, okay, if you meet these criteria for being relatively low symptoms before the peak and these criteria for building up afterwards, we'll call that a pattern, a feature in the data. And what we found was that if you use that framework and then use moving averages and smoothing, sort of highlighted by the blue line with the shading around it, then we did actually see a small effect visible in the data, but only in 10% of the participants. We saw a similar pattern in some other people on other days, but this was more common after the peak activity day than any other time period. So I think actually using this combination of self-report and activity tracking, we did demonstrate something that has been difficult to demonstrate and prove, but we also found that it was rather less common and rather less substantial than many people thought would be the case. So that's kind of what we did in the study, and that's been published in PLOS One earlier this year. The code was earlier. I can go back to it if anybody wants. I want to think now about how you use this to generate feedback. There's a lot of talk in the kind of apps meet psychology world about brief context-sensitive interventions. So, you put something in your smartphone app and it reminds you that, oh, you could be in a situation where you're being tempted to drink, or you're maybe in a situation where this is going to be dragging you down, or you're trying to do stuff and you're too tired. It's a great idea, but it's a bit problematic because the assumption that data at any one point is strong to give that real strong signal is probably a bit naive, and certainly the amount of noise in our data would suggest that that's quite tricky. The naive approach to feedback implies that individual data points matter, and that you're looking for, but actually you've got very noisy data that you're trying to find signals in, and getting it big enough to start to have sort of statistical power is a problem. And that's without the also problem that it tends to be based on the assumption that knowing something changes behavior, which is again not always the case. So we think maybe you need to take a sort of more nuanced approach to feedback from these things, that actually you need to collect data quite a lot over quite a long time to start to see patterns emerging, and these big pictures matter. And actually, to some extent, maybe the noise is the signal, and we'll come to that looking at people's lived experience shortly. And we need to think, how do we actually use that information if we think it's appropriate to change behaviour? So this is study 2, and this was conducted this year, but with 16 people who took part in study 1 more than a year before. Not ideal, but that's just how, not ideal to have that big a gap, but that's how it was. And in the study, we generated a personal report for them, a sort of infographic with visuals and information comprising 2 parts. Firstly, a dummy example built up from 3 different participants' data, so that the point of that was have a look at it and familiarize yourself with what the data looks like. And then a personalized report, now look at your data. We had more volunteers than we needed, so we were purposive in our selection of people to take part. We used a video interview that was recorded. We used a think aloud method, really encouraging people to start looking at the screen and start talking. Give us a commentary as you're looking at it, as you're reflecting at it, as you're trying to make sense of it, with as little prompting from the interviewer as possible. We did have some scripted answers if people asked questions and things, and the graphics came with some printed information to hopefully make them reasonably clear. As I say, the interview had 2 parts. It was all one fluid interview, but there was a, let's look at the dummy report, now let's look at your personal stuff. For the analysis, we took a thematic analysis approach. We did a little bit of kind of taking ideas that emerged from the early analysis into later interviews, but because we were using Think Aloud, we were relatively restricted on that. We still wanted people to think aloud rather than think the way we wanted them to. We used a process of coding to develop themes using regular coding meetings and discussion, and we got a reasonable degree of saturation, data saturation, on the sort of key themes that I'm going to describe now. Oh, before I do that, I'm just going to show you what people saw. So firstly, there was the content 1 was the mean and range. Then there was a correlation heat map. And finally, and this is one that you haven't seen, a plot presenting both the physical activity, which is the blue, and the symptoms, which are the red lollipops. And I think that's done with, we did it with overall symptom severity. But again, you got the same result. It looked the same if you use fatigue. And if you look at that, you can see, yeah, okay, symptom severity bobs around a bit, but there is no 2 patterns look, no 2 days look particularly the same. Well, actually, I've just seen 2 that do, but most days don't look the same. And there are no obvious patterns jumping out. So in the analysis, we started with sort of 4 kind of initial key themes that came out quite early on. The contrast between the data and personal accounts, the variability and unpredictability of the illness, the lack of a clear relationship between symptoms and physical activity, and the independence of anxiety from other symptoms. So I'm just going to take you through those to show you what we found. Firstly, this contrast between a personal account and the data. So we'll give you some quote data. I didn't used to be uncertain and lack confidence in dealing with this stuff, but actually I find it difficult now because of the illness. And this, not only is it difficult, it's difficult to communicate. And just look how many conditional clauses there are here. It makes me feel silly. And then I think, when I'm with people like you, that hits my anxiety then as well, because I think, gosh, I really don't. I'm not giving you the confidence that I know what I'm talking. There's real difficulty communicating about the experience that in people who clearly articulated this didn't used to be them. In contrast to that person with diminished confidence and ability, the data was like an accurate representation. I think this just pretty much confirms what I've been saying for the last 3 years. And everybody just thought I was talking nonsense. It's confirming my belief. It's validating. And this was a repeated theme through the interviews, that seeing the data suddenly took a subjective experience and made it concrete and validating. On variability and unpredictability, again, it allows people to see, it allows other people to access to the person with the illness's lived experience. But actually this unpredictability is a real part of the impact of the condition. I'm still searching to find something to explain the variation. If I could make it more predictable, I'd not be at its mercy so much. And if that's about hope, this is about demoralization. And it's just depressing because you want there to be a pattern. You want to be able to say, I've worked it out, and it's not what you find. And actually I said earlier, maybe the signal, the noise is the signal. And I think, yeah, it is in many ways. So there's challenge of the relationship of symptoms to activity. People had two different ways of reporting this. In the first one, there was the successful activity pacing account. So the lack of relationship between activity and symptoms shows, yeah, I was quite good at pacing. I've regulated this out. There aren't big sort of, I'm not doing crazy amounts of stuff and then afterwards. So I'm succeeding. But there was a different contrasting narrative as well that we heard from a number of people who'd begun to question this. And again, looking at it, they questioned when they saw it. They were kind of engaging their logical, rational, and it doesn't seem to make a difference from that, whether you're doing stuff or not. And again, there's a punch that actually when you look at that and then all the discourse saying pacing is the secret, everybody's got to pace and then they'll be fine. And it feels like a project that you keep failing at. If I just find the right pattern and the right way of doing things, I'll be cured. And so if I haven't found it yet, that's on me. And that's the reason why I'm not better. If that's not self-blame being brought on by well-intended advice, it's awkward. And finally, people looked at the sort of yes, anxiety's there, but they say, we knew anxiety's there, but it's not there. It doesn't look like it's causing the stuff, does it? And I think this one's really important for health professionals because we sometimes do this default thing that if there's symptoms and we can't find the cause for it on the tests on pathology, then maybe anxiety is driving it. But actually, maybe the symptoms without cause are driving the anxiety. And I think the patient view is very much that is the case and entirely understandable from that perspective. So I gave you those initial themes. We did analyze them a little bit, take them a little bit further, and these are called the second order themes that essentially what the data suggests or shows us, I think, is that long COVID diminishes a person's capacity to be what we might call a reliable witness, which is a real problem. In contrast, the data gets seen as a reliable and a true reflection of experience. Nobody questioned the provenance. The view was, I've collected this data, it is real and it is true. And as such, the data validates the unpredictability and the differences between individuals. And when I was, at the same time I was doing this, I was refreshing myself about Lincoln and Guber's criteria for quality in qualitative research. And they used the terms credibility, reliability, transferability, and confirmability. And yeah, I couldn't help but see the similarity of these problems that we highlight that were highlighted in the patient's accounts about being credible, about being reliable, about having experience that was transferable or confirmable. There's real challenges to the lived experience account. So just to wind up, I've got some reflections and conclusions. Reflections on the approach in this study anyway. Well, actually, we were already planning to do this in a different condition at the end of 2019, and we'd had some meetings and the team was kind of being set up. So when COVID happened and long COVID quickly appeared, we kind of made a run for it. The participants in the study were strongly motivated, so we got about 80% of possible entries, which is good. It's a very different approach at the time to the sort of mass survey epidemiology, trying to find phenotypes that way, that's followed and continued. And still, although a couple of the big funded studies have now collected data like this, none of them have yet reported it. And I think for me, the light bulb was realizing that we could use this data in the second phase interviews to understand more about people's experience. A few reflections on long COVID on the basis of this as well. Firstly, that these findings really don't fit with a simple, consistent one-to-one mapping of pathology, whether that's mitochondrial or immune or whatever it is, and symptoms. But actually, it's not that unusual. If you look at similar studies of the relationship between symptoms and physical activity or symptoms and disease activity in other conditions like multiple sclerosis or arthritis, you also see there's heterogeneity of symptoms in time and actually surprisingly weak associations with physical activity. So it's not unique to this condition. But I do think we need to get beyond a kind of naive realism in relation to symptoms that essentially, just there is a direct wire between a muscle in your thigh and the bit of your brain that feels what your legs are like, because that's not how processing of body sensations works, neither for muscles nor for kind of things like the heart and breathing. It's much more complex than that. And actually, maybe it helps us move away from thinking of long COVID as a consequence of damage or of single part damage or continuing infection or whatever as a single thing with an unspecified mapping to symptoms, to thinking that at least in part it may represent an acquired disorder of the signaling both up from the body to the brain and down from the brain to the body through the autonomic nervous system, the immune system, and all of these things. And actually thinking of it as a signaling disorder may give us some important ways forward. Concluding more generally, this is a masterclass about intensive longitudinal methods. Can they tell you stuff that other designs can't? Yes, they can. Are they complicated but doable? Yep. They generate noisy, complex signals, and sometimes, I think as in this case, the noise is at least part of the signal. And I think the thing we've added is that actually using the analyzed data after processing it becomes part of an assemblage of lived experience, data, report, and professional or interviewer that can increase understanding and add value and research. So with that, I'm going to stop and say thank you to Alex Pavitt and Katie Meller, who both had 6 months, 50% placement during their GP training with my team, and did the interviews and quite a lot of the legwork on the second study. Thank the study participants and the long COVID support group for both parts, and colleagues at Hallam University, Caroline particularly, and Helen Dawes at University of Exeter. Thank you, and thank you for listening.